webinar. It's just right on 3:30 at the moment now, and we've got some attendees joining in. So in the interest of time, I'm going to start the webinar right now. I'm just going to go through some housekeeping rules, introduce the speakers, so that way we can get away on their presentation. There'll be people coming in as attendees coming on, and I think they'll be able to be admitted through. So before I start, I'd like to just thank everyone for attending. And today's topic is really the very topical topic on immunotherapy for head and neck cancer. And it is very topical because of the success that we've seen in cutaneous head and neck cancer with cemiplimab. But however, the holy grail still exists on management and these response rates of head and neck cancer in the non-cutaneous setting, especially for non-HPV. So the title is Transforming Treatment Approaches in Head and Neck Cancer, the potential for immunotherapy in neoadjuvant, adjuvant, and metastatic disease. I'd like to acknowledge the traditional owners of the land that we gather here today, and where I'm at, it's the Wurundjeri people. And I'd like to recognize their continuing connection to those lands, water, and culture, and pay our respects to their elders past, present, and emerging. Just a few housekeeping rules before I present the speakers is that the question time will be reserved till the end. So that way, please type. There'll be a Q&A box in everyone's bottom bar so that you can actually type in your Q&As. Both Dr. Alesha Tai and myself will go through them, and we'll be able to ask the actual panels of experts towards that. And to introduce my esteemed colleague, Dr. Alesha Tai, who will be the co-host and co-moderator of this afternoon's webinar. Dr. Tai is a medical oncologist who's based at Peter MacCallum Cancer Centre. And I'm sorry about the windows. I just can't read my notes without them. And she is also the lead for head and neck cancer at Austin Health. Her research explores the interplay between immune system and head and neck cancer, with a particular focus on the cutaneous squamous cell carcinomas and immunocompromised patient and nasopharyngeal carcinomas. So welcome, Dr. Tai, who will be actually co-hosting from Madrid as she's attending ESMO. To the speakers, my other esteemed colleague, Dr. Bryan Bell. Dr. Bryan Bell is a head and neck oncologic surgeon who has actually used his practice based at Providence Cancer Centre to run a lot of clinical trials in neoadjuvant settings. Dr. Bell's work bridges basic translational and clinical activities. He's served in National Institute of Health head and neck steering committees on immunotherapy clinical trials planning group, and in the task force on previously untreated and locally advanced diseases. He's a current physician executive and director Division of Surgical Oncology and Radiation Oncology and Clinical Programs for the Providence Cancer Institute in Oregon, Northwestern USA. Dr. Marka Crittenden is the other panel of expert, is a physician scientist and radiation oncologist, trained both in radiation oncology and immunology as well. She completed her MD PhD and did her PhD work working on immunotherapy that studies the integration of immunotherapeutic approaches targeting the immune environment within the tumor to enhance efficacy of conventional therapies such as surgery and radiation. And since 2009, Dr. Crittenden has actually served as a translational radiation research director at the Earls A. Childs Research Cancer Institute, which is based in Portland, Oregon. And finally, the last speaker is Dr. Leidner, who is a medical oncologist and co-director of the Head and Neck Cancer Program at Earls A. Childs Research Institute and the Providence Cancer Institute in Oregon. And at a national level, Dr. Leidner has also served at the NCI Head and Neck Rare Tumors Task Force. So as you can appreciate, this panel have got experts on both not just medical oncology, but also radiation oncology and surgery, because I think it's a collaboration and it's the combination of treatments that will, I think, lead to better response rates and better outcomes. So without further ado, I'll pass the floor on to the first speaker, Dr. Bryan Bell, who'll be able to actually start the talk. Thank you, Dr. Bell.
Oh, thank you, Felix. Let me just pull this up here. Let's see. Doing this right? How's that?
Yep, we can see a screen.
Okay. How about that?
Yep, perfect.
Great. Okay, perfect. Thank you. Well, Felix, honored to be here on behalf of my colleagues here in Portland. We're really thrilled. You know, in particular, having had a personal connection to you, Felix, from your training. Not only you, but also Dimitri, two wonderful people from down under. It's particularly gratifying to see the great work that you all have done, and with fond memories of our times back here in Portland. As you mentioned, we're going to talk today about neoadjuvant immunotherapy. I'm going to start it off by kind of reviewing the field. Marka will follow me, talking about some of the translational work she's done, particularly with regard to combining immunotherapy with radiation therapy in the definitive setting. And then Dr. Leidner will finish things off with a futuristic look at where things are going in the recurrent metastatic field and in the field overall. Most of us know it's been about 13 years or so since Crittenden and colleagues reported the results of RTOG 0129. And this conclusively demonstrated that tumor HPV status is a strong and independent prognostic factor for survival amongst patients treated with chemoradiation for locally advanced head and neck cancer. Since that time, though, survival has not changed significantly, and a state of clinical equipoise exists with standard treatment options which are ineffective in some patients and overly morbid in others. Most of us are aware that immunotherapy has transformed the practice of oncology, certainly in the recurrent metastatic setting, with checkpoint inhibitors targeting PD-1 or PD-L1, as well as CTLA-4, and most recently LAG-3, with approvals in virtually every solid tumor type, including head and neck squamous cell carcinoma. Unfortunately, as most of you also know, response rates are not particularly robust, particularly in head and neck cancer, which is characterized by an immunosuppressive tumor microenvironment, and response rates probably to single agent checkpoint inhibitor, either nivolumab or pembrolizumab, between 13 to 18% or so. There are biomarkers of response that have been identified, including tumor mutational burden, PD-L1 expression, and gene expression profiles suggesting a T-cell inflamed tumor microenvironment. But none of these are perfect, and to date, only one, PD-L1 expression, is clinically actionable. And this is based on the results of KEYNOTE-048, which is a randomized phase 3 study comparing pembrolizumab alone versus cetuximab with chemotherapy standard of care, or pembrolizumab in combination with chemotherapy versus cetuximab with standard of care. And this, of course, was a positive trial and showed significantly improved survival for patients either with pembrolizumab alone and a CPS score, which is a immune tumor cell score of PD-L1 expression, and a CPS score of greater than 1 with pembrolizumab alone, or in the total population, including non-PD-L1 expressors, receiving responses and an overall survival benefit to the combination of pembrolizumab and chemotherapy. And thus that ushered in our first line recurrent metastatic standard of care currently, which is pembrolizumab alone for PD-L1 expressors, or pembrolizumab combined with chemotherapy for non-expressors. These agents have been tested in the definitive setting and are just being moved into that setting. And despite successful attempts in numerous solid tumors like melanoma and lung cancer. The first attempts in head and neck cancer have failed spectacularly. With Javelin, Keynote 412, and NRG HN004, we witnessed not one, not two, but 3 negative phase 3 trials testing checkpoint inhibitors with chemoradiation regimens in patients with locally advanced disease. The good news is that a number of early phase studies are beginning now to advance the field with novel strategies that I think, if developed further, have the possibility of improving survival and enhancing quality of life in the definitive setting, both critically unmet needs. To hit this target, we begin to answer some of the most important questions or challenges that face the field, including the perioperative, how best to integrate immunotherapy in the perioperative setting, identifying biomarkers, developing new approaches to enhance response to anti-PD-1, and to safely de-escalate surgery or radiation, and ask the provocative question of whether adjuvant radiation-based therapies can be eliminated altogether. In my opinion, one of the most compelling studies to help inform this path forward is in the elegant work from the UCSD group, in which they employed a syngeneic orthotopic head and neck mouse model for regional lymphoablation with either surgery or radiation. And they found that lymphoablation with either neck dissection, which is illustrated on the left-hand side of your screen, or ablative doses of radiation, which are shown on the right, eliminated the anti-tumor response to either anti-PD-1 or anti-CTLA-4 and worsened overall survival. Response to immunotherapy, they showed, is dependent upon intact lymphatics. So we now know that effective neoadjuvant blockade primes T cells, induces proliferation and activation, and enhances the TCR repertoire before the surgeon removes the tumor. This allows for a more diverse population of T cells to potentially eliminate minimal residual disease or subclinical metastatic deposits after surgery. On the right of this screen, data from Christian Blanc's group supports this hypothesis and shows in patients with melanoma that neoadjuvant checkpoint blockade is more effective than adjuvant in eliciting clonal expansion, and that such expansion is associated with reduced recurrence after surgery. Recently, Patel and others showed that neoadjuvant plus adjuvant pembrolizumab is superior to adjuvant pembrolizumab alone, and there are now neoadjuvant FDA approvals not only in melanoma, but also in triple-negative breast cancer and non-small cell lung cancer. Finally, pathologic response to immunotherapy is strongly associated with survival. In particular, major pathologic responses characterized by less than 10% viable tumor cells in the resection specimen. This, of course, poses the question as to whether or not pathologic response can be used as a surrogate endpoint for survival in clinical trials. If so, how deep does that response need to be to see a benefit? Is 50% okay? Is 20% enough? We are all aware of the promise of immunotherapy, which lies on the tail of the Kaplan-Meier curve and implies that with the right combination of immunotherapies, targeted therapies, or other agents, responses to immunotherapy will be increased and more patients will survive. Well, this is the promise of neoadjuvant immunotherapy, and it lies in the waterfall plot, that with the right therapy at the right time, with the right biomarker, pathologic response will be enhanced, surgery and/or adjuvant therapies will be de-escalated or even eliminated, and survival improved. Unfortunately, in head and neck cancer, response to single-agent checkpoint inhibitors is quite modest, generally less than 8% in either HPV positive or HPV negative disease, and biomarkers such as PD-L1 are not consistently predictive of response. Major or complete pathologic responses are rare indeed. There are some learnings, however, First, that RECIST response does not always correlate with pathologic response and is an unsatisfactory endpoint in the neoadjuvant setting. There are also discordant responses between the primary tumor and the metastatic lymph node. Just because a primary tumor responds doesn't mean that a metastatic lymph node will. We all await the results of Keynote 689, which is the phase 3 trial studying pembrolizumab, neoadjuvant pembrolizumab versus standard of care in resectable head and neck cancer. And this should finish accruing in the fall or probably early next year. And we hope to have an answer as to whether or not this approach improves survival compared to standard of care. Time will tell. Importantly, Trish Wise-Draper showed us last year in 92 patients treated with neoadjuvant pembrolizumab that any treatment effect in greater than 20% of the resection specimen appears to be associated with significantly higher survival in at least histopathologically indeterminate risk, intermediate risk patients. And this gives us additional confidence in its potential as a surrogate biomarker. 3 groups have attempted to enhance pathologic response by combining PD-1 or PD-L1 inhibitors with CTLA-4. Importantly, the combination increased the number of patients with major pathologic response as well as clinical to pathologic downstaging, but pathologic response remained elusive, or complete pathologic response, I should say, remained elusive, and non-responders still relatively common regardless of HPV status. Here again, the waterfall plot looks better, but without good predictive biomarkers, we're not yet where we want to be. Other groups, like Joe Curry's group from Jefferson, have attempted to enhance response using immunotherapy or immunomodulatory agents such as tadalafil. While this has not been carried forward, it does show some important and interesting changes in the tumor microenvironment that might be actioned upon in the future. LAG-3 is the third class of checkpoint inhibitors that has entered the clinic and is a promising addition to our armamentarium. LAG-3 acts as a signal disruptor and mediates an inhibitory function by associating with the TCR-CD3 complex, impacting downstream signaling. The LAG-3 inhibitor relatlimab was recently tested in a phase 3 trial in combination with nivolumab in patients with melanoma and resulted in significantly better PFS than nivo alone and has led to FDA approval in that disease. In an abstract that I reviewed at ASCO earlier this year, Bob Ferris and colleagues have clearly advanced the field by showing that the combination of neoadjuvant nivolumab and relatlimab prior to surgery in patients with locally advanced head and neck cancer resulted in both major and complete pathologic responses in a significant number of patients. However, a third of the patients in this study failed to respond, and the addition of relatlimab did not really appear to decrease the number of non-responders compared to those treated with nivo alone or the combination. So perhaps this could be improved with the right biomarker, and as shown in the flow cytometry data here, the CD8 Treg ratio was significantly associated with major and complete pathologic response, supporting its use as a potential or exploratory biomarker. Diving a little deeper, that group used single-cell RNA-seq to demonstrate that patients with major pathologic response showed increased effector memory CD8 TIL post-therapy, and also that baseline LAG-3 expression on CD8 TIL may predict the pathologic response to the nivo-rela combination. So besides IO combinations, there are other approaches that are being explored in the clinic to enhance the frequency and depth of pathologic response to neoadjuvant therapy. In this interesting study, Zhang and others from China showed that the combination of paclitaxel and cisplatin combined with the PD-1 inhibitor camrelizumab downstaged 100% of patients with locally advanced HPV-negative head and neck cancer prior to surgery and resulted in a strikingly high major pathologic response rate of 74% with a complete pathologic response rate of 37%. Clearly, the waterfall plot is starting to look better. In another approach, this study also presented at ASCO earlier this year. Laura Dunn from Memorial Sloan Kettering presented early results of a neoadjuvant study testing a combination of chemotherapy with cemiplimab. Here again, they showed a high rate of clinical and pathologic downstaging prior to surgery, but they also baked into the protocol the elimination of conventional risk-adapted therapy for patients with significant pathologic downstaging and added adjuvant cemiplimab. They showed a 60% major pathologic response rate and 40% complete pathologic response rate, and 4 of 10 patients did not have to undergo adjuvant therapy. Importantly, they also included surgical modifications as an endpoint. And amongst the 10 patients treated thus far, 5 of 8 were planned for mandibulotomy and avoided this potentially morbid surgery, and 7 of 10 avoided the addition of additional morbidity of a free flap. Any surgeon on the call tonight will know that this is truly impactful de-escalation. So one of the questions that has been answered, or that has been asked by many people, despite these impressive response rates, is does chemotherapy blunt the immune response? And if you look back at Keynote 048, the duration of the responses in the group that received chemotherapy and pembrolizumab compared to the pembrolizumab group alone failed to, or had less duration of response than those without chemotherapy. So it does raise a provocative question, and this is where I'm going to turn it over to my colleague, Dr. Crittenden, who will take us through our interest in a novel approach that avoids chemotherapy, combines the use of hypofractionated radiation therapy delivered to gross tumor volume only in combination with a checkpoint inhibitor to increase pathologic response, major and complete pathologic response, and hopefully de-escalate our surgery and need for adjuvant therapy. So I want to thank everybody, and I'll look forward to taking questions later. Go ahead, Marka, take it away.
Right, thank you. I do want to apologize because I am battling a little bit of bronchitis. So I may periodically have a coughing fit. I hope not. Okay, so tonight I'm going to be talking about, or this afternoon for you all, neoadjuvant immunoradiotherapy experience at our institute, which is really about the phase 1 clinical trial. Just our disclosures. For an outline for the talk, I'm going to be giving you a little bit of background and rationale for the combination of radiation and PD-1, really with the idea of targeting the PD-1 to enhance the local control with radiation and surgery. So that's in the combination in the neoadjuvant study. And then I'll be actually talking about our phase 1 clinical trial. So when I think about radiation and immunotherapy, I break it down into sort of 2 mechanisms for synergy. Synergy 1, which is spoken about a lot, is the idea that radiation can kill cancer cells, release antigen, and function as an in situ vaccine, that when you give immunotherapy, it can sort of prime the T cells that can then go and control distant disease. But another effect of radiation and immunotherapy is that when you radiate cancer cells, you induce changes within the tumor environment, particularly on the cancer cells themselves, that can result in them becoming better targets for immune-mediated clearance of residual local disease. And this is often termed immunogenic modulation. So this is a graphic that Charlie Benson put together in a review in 2016, showing all of the effects that you can see with radiation. Radiation is known to recruit activated T cells into the tumor microenvironment. Let me just see if I can get a label. So draw T cells, but also gamma delta T cells and NK cells, all of which are killer cells capable of killing cancer. And then within the tumor itself, or on the tumor cell itself, it can upregulate a series of markers, including class 1, which presents the antigen on the surface of the cell, as well as FAS, which can target a cell for death if it engages FAS ligand on a killer cell. And then as well as the NKG2D ligands, which can result in enhanced NK cell killing. But another consequence of radiation is that it can upregulate certain things that can downregulate or shut off immune cells, killer cells, which of particular interest is PD-L1. So knowing this, we looked preclinically at radiating a cancer cell line that was a oral cavity derived mouse line, and used increasing doses of radiation and looked at what happened in terms of the expression of several of these markers on the surface of these cancer cells. And you can see that class 1 goes up in a dose-dependent manner, so that by the time you're getting to about a single dose of between 5 and 10 gray, you're getting a meaningful upregulation of class 1. Similar range, you're starting to get a meaningful upregulation of FAS and KG2D ligand. But you can also see that PD-L1 is coming up on these cells, which would engage PD-1 on the surface of the killer cells, be they T cells, gamma delta cells, or NK cells, and shut them off. So the rationale for this study really is that local failure and local toxicity and head and neck cancer are both significant issues. It's an ideal disease site, we felt, to look at the role of PD-1 axis inhibition in order to enhance local control with radiation and surgery, potentially de-escalating how we give our radiation, giving it in the preoperative setting to limited sites of disease, because the immunotherapy is going to enhance our control. And then that sort of goes to this concept of dose reduction, and that in the neoadjuvant setting, we can really look at the pathologic consequences of the treatment. So the clinical trial that we designed included HPV positive patients and HPV negative, but cohorts 1, 2, and 3 all were HPV positive. They all had to have upfront indications for adjuvant radiation therapy prior to TORS. So if they looked like potentially they were a surgical candidate only, they weren't eligible for the study, because we didn't want to radiate any patients who didn't require radiation upfront in the adjuvant setting. The first cohort included 5 patients and was treated with nivolumab, followed by a week of radiation, 8 gray times 5 fractions, using an SBRT technique treating gross tumor only. So there was no elective nodal radiation, only clinically and radiographically positive disease was treated. Then they got 2 additional cycles of nivolumab, and then went on to surgery around week 6, which was the standard of care surgery. And then depending on their response, some of the patients were able to omit the adjuvant radiation therapy if they downstage sufficiently. The second cohort also received nivo, but a lower dose of radiation, 8 gray times 3. And the third cohort did not receive any nivo, but did receive the radiation. And the primary endpoint was, of course, safety. Could this be done and not delay radiation? And the secondary was overall response, or rate of response, in both clinically and pathologically. And then the fourth group was pretty much the same, but it included HPV negative patients. And this is an example of a radiation plan. So this is a tonsil extending onto the palate, and you can see nodal disease here. And then this is the pre-treatment and post-treatment, and you can see there's persistent disease in the palatine tonsil and persistent nodal disease. So radiographically prior to surgery, we could still see disease in many of these patients. This was the RECIST response rate. So you can see by RECIST, we didn't really see any complete pathologic or complete imaging responses prior to surgery. However, for pathologic response rates, we had, this is the waterfall plot, we had major pathologic response rates in the majority of the patients, even in the HPV negative group, and greater than 50% in all of them. And then at a median follow-up of 4 years, the recurrence-free survival is very high, 80% and higher in all 4 cohorts. The overall survival is 100% in the HPV positive, only 40% in the HPV negative. One of those patients died of disease. The other 2 that passed away died of stroke and second malignancy. So to summarize this, combining radiation and immunotherapy, the immune system can enhance the local control of irradiated tumors by changing the microenvironment. It enables us to enhance local control if we combine the 2, and that by targeting gross disease, we can decrease some of the complications associated with radiation, including dry mouth, taste changes, swallowing difficulties long term, and that because of the high rate of downstaging, we're exploring this further in a larger phase 2 study. And I will hand it over to Ram to finish up.
Thank you, Marka. So I'm Ram Leidner. I'm the medical oncologist in this trio. And I'll be talking about the recurrent metastatic setting. These are my disclosures. So I guess has already been alluded, the standard of care now in first-line recurrent metastatic disease is based on the KEYNOTE-048 study. And for all patients receiving pembro and chemo, there was a significant survival benefit. And then there was further stratification, as I think everybody on this call knows, by CPS, less than 1, 1 to 19, and 20 and above. I'll just point out that with the combined positive score, it requires a minimum of 100 viable tumor cells in the PD-L1 stain slide. And so I doubt pathologists are going into the thousands on this. And so the meaning of this really is that if there are 2 PD-L1 positive cells, whether they're tumor or immune cells, that's basically a CPS of 1. Less than 1 is 1 cell or 0. And as a consequence, 85% of patients will meet this cutoff, and pembro monotherapy has been approved in that setting. And that de facto in the States has become the standard, pembro alone. But as a note of caution, these 2 curves, these are the progression-free survival curves from the KEYNOTE-048 study. So on the left are those patients that, and this is for the lowest risk group, the patients with a CPS of 20 or greater, both of these curves. And so these would be expected to perform quite well with pembro alone. And in panel A on the left, you can see that there was a die-off initially and then a decusation of the curves. Ultimately, the disease-free survival rate is much less than the overall survival rate at the same time points at 2 and 3 years out. On the right in panel D is pembro with chemotherapy. Again, not outstanding long-term results, but it is a note of caution. So pembro, I feel, is kind of reaching its shelf life, seated on the perch of the go-to standard for first-line recurrent metastatic. But despite many attempts at combination therapy, no combination has been able to unseat pembrolizumab at this point. I think the most promising currently is the Bicara EGFR fusion protein with TGF-beta R2 trap domains. And as you can see in these waterfall plots from ASCO this summer, presented by Glenn Hanna, the HPV negative group was quite superior in response to the HPV positive. And so the phase 2, excuse me, the phase 2 randomized trial going forward is going to be an HPV negative alone. And so there is some promise here for the HPV negative group, which is a relief. I think in the last few years we've thought we're going to make big strides in HPV positive, yet the need and the recurrence risk is much higher in HPV negative. And now it seems that actually we're getting some traction in HPV negative, whereas in the second line HPV positive setting, I don't think we have any consensus at this point. Our entry to the first line recurrent metastatic setting is built on a backbone of a multivalent autophagosome vaccine that I'll explain in a minute, with a 2-week delay before starting PD-1 blockade, and that's in the control arm, if you will. And in the treatment arm, we have the addition of an agonist antibody to a co-stimulatory molecule in the T cell synapse known as GITR. If you like using the automotive analogy, the vaccine is putting gas in the tank, the PD-1 is taking your foot off the brake, and the GITR agonist is pressing on the accelerator. So the multivalent autophagosome vaccine was developed in-house. It's based on in vitro cell lines with blockade of the proteasome and the lysosome with bortezomib and ammonium chloride, respectively, which shunts short-lived proteins and defective ribosomal degradation products into the autophagosome, which can then be fractionated and the vesicles used as a vaccine. These are highly immunogenic, but they're short-lived, and they're enriched in cancers. We've shown that in preclinical models that the trio combination of co-stim agonist GITR with a vaccine with PD-1 it improves therapeutic efficacy in this mouse model, as you can see here, with the triple combination in the inverse triangle, the curve that survived past 80 days. And other work that we've done, Bernie Fox and David Messenheimer. The prior slide was Hongming Hu and Dr. Jaina Patel at our institute. Another lab, Fox and Messenheimer, showed that in combination with OX40, another co-stimulatory molecule, a delay of the PD-1 is beneficial, shown in green here in these tumor outgrowth curves in the polyoma middle T model, whereas co-synchronous administration is deleterious, as shown in red, versus the co-stim alone, OX40. And so that's the rationale for this trial. The trial had a safety run-in of 3+3 in each arm, and then it's randomized 1-to-1 between the two arms. There is a low dose of cyclophosphamide given 2 days prior to the first vaccination, which you can see in gray. The first vaccine is delivered intranodally in the inguinal nodes under ultrasound bilaterally. All subsequent vaccinations are delivered in a very shallow intradermal approach. You can see in blue that the first PD-1, in this case retifanlimab, is delayed 2 weeks and then given every 4 weeks after that, along with serial vaccines, which I'll show in a moment. In the arm 2, then we have the addition of the GITR agonist, which is given simultaneously with the start of vaccination in red, as you can see. The stratification is by HPV status and PD-1 CPS 20 or greater. So this is the treatment schedule on the backbone arm of vaccine and delayed PD-1. In green there, you have the single dose, the priming dose of cyclophosphamide, low dose. The day 1 vaccine in the black triangle, that's intranodal, and then the white triangles represent intradermal vaccination. Blue squares are the PD-1 every 4 weeks with a 2-week staggered onset of delivery. And then biopsies are at the 3 time points you see there at baseline, 2 weeks and 8 weeks. We've had no difficulty getting 3 biopsies. And if you invite me back, I'll talk about a cell therapy trial where we've actually done 5 biopsies without difficulty. But the key is getting, and this is just an aside, the key is getting the biopsies early. By week 8, we're doing our first CT scan. That's an unconfirmed result. And then at week 12, we do the confirmation CT scan. And at that point, if somebody has progression, they're not going to agree to any more biopsies, or if they're not having a robust response. it's quite difficult at later time points, and that's a flaw I see in much of the pharma design trials, trying to get biopsies at 3 months out and such. Here's arm 2. It's identical to arm 1, the one difference being the red circles, which represent the GITR agonist, biopsies at the same time points. And the days listed there are all the time points at which we draw blood for analysis, which is what I want to talk about. So I want to, in terms of what we've seen in the peripheral blood thus far, I want to focus on 2 kind of notable findings. One is this is our B-cell gating strategy in the blood, and that has to do with the plasmablasts. So in arm 1 on the left, you'll see that in the initial 4 patients, we haven't seen any fluctuation in the plasmablasts, but interestingly, in arm 2, with the addition of the GITR agonist, we see a spike in some of the patients at day 8 in the plasmablasts, which then normalizes by 2 weeks onto the study. And note, at that time point, when we draw the blood at day 15, the patients have only received GITR and vaccine. They have not received PD-1 blockade at that time point. So this is strictly an effect of GITR, given that we don't see it with vaccine in the absence of GITR. And interestingly, the patients that had this spike did poorly, whereas the patients that did not did better. And so the highest spike in blue there, patient went from completing cycle 1 in the DLT period into hospice. The next 2 patients in black and orange, black did not derive benefit from the study and went on to other treatments, and the red patient had stable disease, but has since gone off trial and received other treatment. The other interesting finding in the peripheral blood has been the MDSCs, the monocytic MDSCs. Here, this is the gating strategy. And again, we seem to see a differentiation there. And so I'll start on the right this time in arm 2. The patient in blue, which did so poorly, also had a spike at day 8 in the monocytic MDSCs, which we think are trafficking from the marrow to the tumor as a response to therapy. And then over on the left in the control arm, we have 2 patients that showed a spike at day 15. It was a bit delayed relative to the GITR arm, and 2 patients that did not. And if we look, these are the results thus far. So on the top in arm 1, we've had 1 partial response, and I'll note that that patient did not have a plasmablast spike, nor which is strictly in the arm 2 with GITR, but they also did not have the MDSC spike. 2 patients that progressed had the day 15 MDSC spike, and there's more data that's being batched. In arm 2, we've seen 2 complete responses. You'll see there GDP09 and GDP11. And if you trace over, you'll note that they did not have either of these spikes, whereas patients that had the plasmablast spike or had the MDSC spike, or in the case of GDP10 had both, did quite poorly. So I want to tell a tale of 2 patients essentially in the tissue analysis we've done. So the first patient is the patient in red, GDP02, who had the day 15 MDSC spike in the peripheral blood. This is multiplex immunofluorescence with digital spatial analysis. In green, in the cyan or aquamarine, those are the cancer cells. Some of them are rimmed with red, which is PD-L1. The emerald green cells are the Treg. And so none of this is good. What we want to see are yellow cells, of course, the CD8 positive cells. And if you look around, you can find a few CD8s in the tumor. This is at baseline prior to any treatment. But if we look at the 2-week time point prior to any PD-1, and this was in the arm 1, so it was vaccine and alone, we see quite a bit of inflammation induced in the tumor. You see red PD-L1 everywhere. You can see the green cells. What's notable is the yellow cells are now absent. The CD8s, I don't think I can find one, but I see a lot of orange cells, the macrophages, or the CD868 positive monocytic cells. And predictably, this patient did quite poorly. When we quantitated the the nice thing with this platform is that we can quantitate just like we can in blood with flow cytometry. And so you can see on the left the CD8 density between baseline and 2 weeks on study, whether you look in the tumor or at the stroma, is going down, whereas the Treg density is going up, in particular in the stroma. The next patient is the blue patient who actually had a response. And so what did we see here? This is a baseline, and we are on the right quantitating the contact between the yellow CD8 positive cells and the tumor cells, so we can get a nearest neighbor assessment of that ratio. At the 2-week time point, and there will be also the 8-week time point, we actually saw a decrease in terms of the proximity of CD8 T cells and tumor cells, represented here by much longer lines on the right. And when we quantitated that, that's indeed what we saw, and it was a significant decrease of CD8s in the tumor in contact with tumor cells at the week 2 time points. But then that reversed by week 8, and this is what it looks like. It was significantly improved, and so you can see here an abundance of CD8 T cells in contact with blue tumor cells. And this is another section showing the same thing. So that is one aspect of what response would look like. Further data in this patient, you can see furthest to the right that the CD8 to Treg ratio was significantly increased at the 8-week time point, but not so at the 2-week time point. And if we'd stopped at the 2-week time point, we would have been too impatient and missed the miracle. The aspirational ultimate goal in this study is to demonstrate in human what we've shown previously in mice, that there is a coordinated B cell and T cell response to tumor antigens, and that will rely on whole proteome phage display arrays, as well as deep TCR sequencing in the tumor, and analysis on the digital spatial platforms I've shown you. So that is a long-term project. But for us, we have an approach that we think may have some benefit in theory, but we want to really do a decent job of trying to learn something immunologically in these patients as we go along on the trial. How much time do I have left? Okay, I have 3 minutes, correct?
You've got
Just
time.
say the teacher. I'll say
fine.
this in 1 minute. I'm over time. I'll stop.
No, you're good. You're good.
I'll say one thing. We are on the doorstep of bona fide Treg depletion in humans. The CCR8 antibodies are finally looking promising. We as a group did a study long ago. Maybe Felix was even seeing some of these patients where we did a punch biopsy in the clinic of oral cancer, gave a microdose of anti-CTL4 ipilimumab, 1% of what you would give in IV systemically. And then at 4 different time points, the patients received standard of care surgery. And we compared the tissue before and after to see what does ipilimumab do in the tumor. Our prediction was that we would show Treg depletion. At that time, the technology was restricted to these small regions of interest, and it misled us. We saw actually an increase in orange here in the Tregs in the tumor at the time of surgery, whether it was 3, 7, 10, or 14 days. And so we gave up, and we just had to agree with Pam Sharma and Jim Allison that ipilimumab does not deplete Tregs in tumors. Well, the technology's moved along quite a bit. We now have whole slide imaging, and this is the same tumor section I just showed you on the old and the new, and we've been able to demonstrate bona fide Treg depletion in every patient. Here's the data, and I'll stop there. So you can see before and after, 3 days, 7, 10, and 14 Treg depletion. The problem is that ipilimumab doesn't solve the other problem, which is diminishing CD8s in the tumor. As you can see here, in some cases, the 8 to Treg ratio goes up. In others, it doesn't. And so there's more to the picture than just removing the Treg. I'll stop. Thank you.
Thank you so much for Bryan, Rom, and Marka for their talks. We've got a question from Eric Koo for Marka, which is SBRT of 8 grays times 5 fractions is a form of dose escalation, even though the total dose is lower numerically. Just wondering how you pick the dose fractionation and rationale of SBRT rather than the modulated RT.
So 8 gray times 5 EQD2 is 60 gray. So that's the equivalent of 2 gray per fraction dose of delivering 60 gray. 8 gray times 3 is around 30. I just did the calc. I think it's around 36 gray. So that's definitely a dose escalation, 8 gray times 3. It's also a dose escalation in the sense of the volume the volume of the neck that's receiving 60 gray. So, typically if I'm doing an adjuvant head and neck case, I'm treating the ipsilateral neck and the tumor bed to 60 gray and the contralateral neck to 54 gray. In this case, only the gross disease is treated to either the 8 gray times 5 or the 8 gray times 3 dose. So in that sense, it was definitely dose de-escalation. The patients have significantly less fibrosis long-term, better swallowing, better salivary function, much lower dose to all the organs at risk between what I would see with a standard adjuvant. Now, for one of the patients did require, only one got adjuvant, and effectively that patient did end up getting slightly higher radiation than they would have if they had just gone adjuvant radiation alone. They needed adjuvant chemo and the HPV negative.
And to follow on, I guess, from that question, with that one patient who required the adjuvant radiation, was there any sort of significant tox later on that was noted?
No, they had this patient had Hodgkin's disease of childhood, had an HPV negative radiation-induced malignancy that just didn't respond to anything. So they had a lot of toxicity, but it was tumor recurrence because they got no meaningful local control with radiation, surgery, chemo, rads, chemo, nothing controlled that disease. In the phase 2, we've had people get it. Adjuvant, and oftentimes they can, like if they had a past CR in their primary tumor but had more extensive nodal disease, like microscopic nodal burden, we just want to cover the nodal zones we didn't cover. And so they don't tend to see excess toxicity because I wouldn't re-irradiate the tumor bed if they had a past CR, but they had like low neck nodes that weren't clinically apparent, but I want to cover that. So that's sort of how we've handled the adjuvant radiation portion.
We've got another question from Eng Ui. So with oral cancers that have a partial response and surgeries planned, do you do the resection based on new imaging and the downsized cancer or the original imaging?
We should let Bryan answer that.
I'll take that one. So the question is, do we resect to our original tumor margin or to the regression bed? And the answer is the latter. In all of these patients, we'll resect to reasonable 1 centimeter margin or so as we would normally, but to the regression bed. One of the interesting caveats is we learned pretty early on you can't rely on radiographic response. In fact, sometimes in the post-radiation pre-surgical CT image, it'll actually look like you have progression. And we've had a number of these that were actually complete pathologic responses. So we know we can't trust the CT scan in that at least in that window. And we'll go ahead and resect to the regression bed. The extent of our neck dissection is the same as we would normally do. In general, it's a selected neck dissection that clears the nodal basins at risk. The other thing that we do differently is, and I mentioned it in my talk a little bit, is the planned reconstruction. So many of these patients, particularly in our phase 2 study, which is a HPV negative study, many of them are oral cavity patients that would have required free flap, radial forearm, for tongue cancer or what have you. In a significant number of the patients that we've enrolled thus far, and the study's still accruing, I think we've enrolled 14 patients out of an expected 27. But in a significant number of patients, we've been able to avoid a free flap, avoid a tracheostomy, make it a much simpler operation than it would have been. And that again is truly meaningful in a patient that's looking at a hemianglossectomy or subtotal glossectomy, and instead gets, just a small partial.
I have a question for Ron. Were there any particular patterns of failure from the neoadjuvant study that made you pause or change the design of the subsequent phase 2 study?
Let's see. That might be a better question for Marka, but I'll say on my end, we felt that we had to delay the start of adjuvant PD-1, right, to at least 2 months out. People, as we discussed just before we started, people were just too sick to tolerate that. Marka, do you want to comment on patterns of failure? We did not see any distant failure.
Yeah, so there was no distant failure. There were 2 HPV positive failures. One in the ipsilateral low neck level 5, salvaged with surgery, then recurred and salvaged with radiation, and disease-free and still alive at this time. And then the other was contralateral neck node that became clinically apparent about a year out and salvaged with surgery. That one was salvaged with surgery. And then the other one was the one I mentioned, who was the HPV negative patient who was an in-field failure, in surgical field failure, in radiation field failure. And he went on to a clinical trial, but unfortunately succumbed to his disease.
And I guess to follow up on that, I think with the study you mentioned that you really only irradiated the gross tumor volume to avoid the draining lymph nodes, and obviously some of the failures were outside the irradiated field. Do you think that there's a way to strike a balance with that in terms of avoiding the draining lymph nodes, but also, trying to ensure that there's no recurrence?
I think it's tricky. I think it's it's going to be a decision about what is an acceptable rate of recurrence and how salvageable is it. I think you can't do these doses to elective nodal volumes. And once you start doing elective nodal volumes, you're really just doing standard radiation. So the reason why with standard radiation, I think it's difficult to combine with immunotherapy is partly because we treat the draining lymph node, but also, most of my patients have significant lymphopenia associated with standard fractionated radiation for up to a year out. You're continuously hitting whatever activated T cells that are coming back into the tumor, like Ram showed in his biopsies, with radiation day after day after day. And so I think the shorter courses of radiation delivered within a week would really eliminate that bombarding the tumor environment where activated T cells are coming in with radiation, because it usually takes about 5 to 7 days for T cells to traffic from the draining lymph node to the tumor site.
Well, there aren't any more questions that have been put up, so I'll hand back over to Felix to close up.
Thank you, Alesha. I've actually got one question for Bryan. With possibly more increasing neoadjuvant trials in the surgical setting, can you give us your insight about how the tissues behave, what the tissues are like, in patients who have received neoadjuvant immunotherapy, and maybe perhaps if the neoadjuvant radiation is probably not something that we'll be seeing here, because that's kind of quite a different concept. But how do the tissues behave? Like, are they quite different? Do they have a higher rate of wound complications, dehiscence, healing rate, and so forth?
That's a great question, Felix. We've been doing neoadjuvant studies now with testing various immunotherapy agents, including checkpoint inhibitors and co-stimulatory agonists, and sometimes with off study with chemotherapy, sometimes and an on study with radiation. So we have pretty good experience with this over the last 12, 14 years or so. And I could say that in general, most immunotherapies do not substantially affect the surgical bed. This is not anywhere near as difficult as operating, for example, on a radiated neck. You don't have the fibrosis that you have in a radiated neck. You maintain the dissection planes very nicely. There are some caveats. I kind of alluded to them earlier in terms of, not relying on imaging. You have to rely on, on feel and touch in terms of assessing the response. But in general, the operations are not complicated. We and others have shown that neoadjuvant immunotherapy is quite safe in the perioperative setting, and really, it's pretty much routine surgery.
Great, thank you very much. Well, if there are no other questions, which I see there are none, I'd like to thank you all. Thank you, Bryan. Thank you, Marka. Thank you, Rom, and thank you, Alesha, for the webinar. That I think I found it quite fascinating, and I hope it's been the same for all the attendees as well. I know it's getting up close to 10:30 in Portland time, so I wish you all a good evening and happy Saturday night there. And for the other attendees who are still here and participating, thank you all for taking time of your Sunday afternoon. I hope it's been useful. We do have a post-webinar survey that would be grateful if you can all complete, because your feedback essentially is essential of how we can structure and program our upcoming webinars for the following year. So again, thank you very much to everyone, and I'd like to close the meeting. Thank you very much.